You know, and we talk in clinical medicine about pearls. Pearls are little things you keep at your disposal. They're little nuggets of practical wisdom that help you out to solve problems. What are the things that we want to know that you need to be armed with going out into your practice careers so that you don't say, oh my God, how did this happen? Expect the unexpected and have a toolkit and a conceptual structure around which you can organize your thinking. At the same time that we can start to address some of the bigger structural problems that James and David have identified, because we're going to continue to see these flare-ups and these continued, explosions, and without a legitimate framework for which we can deal with it on a global level. And I think, there's this new publication that I just came across today from the World Health Organization. They're kind of doing a one-year analysis of, they're looking for a critical cause and they're looking for the faults and why this all happened. And a lot of that's going to be going on. There's enough blame for everybody here, and I'll go back to James's point about, what happened back in April and May when every Ebola expert in West Africa said, we got this one wrapped up, let's go home. Everybody was wrong, so there's no point in scapegoating the WHO. Let's strengthen institutions, let's work together, let's try to find a way to make public health and global public health the priority for the 21st century. So that's what I've learned.
That's great. I feel like I've learned a lot just listening to both of you. If I'm allowed, rather than proceed directly to my 5 whys, which aren't necessarily that enlightening, I actually wanted to ask you, because it is striking how surprised people are whenever this happens, and it happens repeatedly, and there's always this surprise factor that you seem to have to deal with. This is the world. I mean, plagues and pestilences are part of the scenery. There's an Albert Camus line, which is that people always think that plagues and wars happen in times other than their own, which I think is very true. And I have wondered to what extent, you can have you can try and teach this, didactically and say this will happen again and again. But is there something about us that we're hardwired to think that, that these are things that when they're not happening, we have the ability to say this will not happen. It's unimaginable. It's not happening right now. I choose not to imagine it, or I can't imagine it because it's not going on. Because there seems to be almost this reset button that happens. 6 months after the last Ebola case, you can ask someone about it. I'm projecting sometime in 2017. Ask someone what they remember of that. The horrors of Ebola in West Africa in 2014, and they'll probably yawn at you.
Yeah. That's a good point. So the other philosopher I like to quote is George Santayana, says those who do not remember the past are condemned to forget it. But I often put a picture of him up with Korsakoff's name on top, because we have kind of a Korsakoff syndrome is this syndrome you get when you drink too much, where you have a complete failure of short-term memory. And I'm trying to figure out what the unit of short-term collective memory is for our society, because it's not 5 years. It's like H1N1 never happened. So is it 6 months? Are you right? I mean, I'm puzzled by this. So I'm completely, I think, it's okay for the media and the public to be surprised when these things happen, but for professionals in public health, we should not be the ones that are shrugging our shoulders going, oh my God, how did this happen? We should be the ones that are taking leadership and saying, okay, let's deal with it.
Yeah, I would just comment on that and say that, I think we are hardwired to forget and to move naturally into little kind of days of comfort. We don't like turbulence. We want to get into the rocks where it's kind of cozy. And I think we are naturally hardwired in that direction. And you can look at cognitive science, and you can look at you can look at cognitive science, and you can see that in fact that's true. There's good evidence for that. But I also think what makes us, in some ways, unique as beings, as biological beings, and as a species, is our ability. I shouldn't say ability. I should say our capacity, our potential, our capacity for insight. Right? That we can learn, and in fact, it probably is, I don't think it would be an overstatement to say that as human beings, many of the problems that we face globally are actually a function of our incredible ability to learn and our incredible ability as a species to adapt and to change through learning and to create conditions that allow us to thrive, even at 7 billion over in a really short period of time of human history, really 400 years. We've gone from 1 billion to 7 billion. It's unbelievable. We're adding 1 billion people to our number every 13 years now. And I think that's really, in many ways, a function of our success in learning. So I don't think we should, and not that I'm suggesting you're doing this, but I don't think we should just say, oh, well, it's just the way we are. We are that way, but we're also this way, right? We can learn. And that's why I frame my comments as this is an opportunity. We have had many opportunities and to learn, right? And will we have more opportunities to learn? Well, in this domain, well, that really depends on what we learn, right, from this opportunity. So we can learn, and we can change the way we see the world and ourselves in it, and the way we therefore behave in the world, and therefore the degree to which we create risk or not risk, or minimize risk, and so on and so on. So I just put that as an additional comment.
Should we open the floor?
Sure. That sounds terrific.
I have to ask a question. And let me begin by saying that it's been a very humbling experience for many of us, including me, that this has happened, something we never would have guessed a year ago, and a good lesson for keeping an open mind. And there's a lot, there's some that three of you said that I agree with a lot, I kind of roll my eyes at, but there was one thing that really caught my attention. It's that I believe all three of you characterize this as a global health issue. Now, by my count, somewhere in excess of 99.9% of all of these 20,000 human transmissions have occurred in 3 countries. And there have been only 3 transmissions, total 3, outside of West Africa, all of which occurred in intensive care units of hospitals. 2 in Dallas, one in Madrid. I'm questioning why we would call, I know we all have this kind of global paradigm, interconnectivity paradigm. I think this is, seems to me the facts of this speak to exactly the opposite. It's that conditions can be so different. In some parts of the world, a disease like Ebola that has no capacity for sustained spread in almost the entire world can find a foothold. That's what surprised us so much. Can find a foothold and actually cause an outbreak of this magnitude. But I'm not sure why we characterize that as global. It doesn't mean there shouldn't be a global response. Don't get me wrong. I'm not saying it's not all of our problem, because indeed it is. But it's in the context of, is it a global threat? Because that's how it's perceived. You go to emergency rooms in Ontario, and there are all these precautions. I don't think they're wearing spacesuits anymore, but they did for a while. There's this perception. Part of your emerging infectious disease paradigm is that it's a threat to all of us. I would think the facts of this actually say exactly the opposite. So the question is, why do you call it a global problem?
So here's one way of thinking of it. So the capacity for people in high-income countries to prepare for this, maybe over-prepare for this, is one thing. But the discussions I was at were the fear that it would get somehow, because there is actually a fair amount of back and forth, and Cameron Khan's not here, he probably have the map of air travel, to some place like Mumbai, Calcutta.
But it hasn't happened. I mean,
it hasn't happened, but that's
and the reason is because the poor people who get Ebola virus don't fly places.
To push back at you then, is it only a global health problem when you have transmission and it does, or do we need to think of it as a global problem when the IHR kick in and people start to make preparations so that, I mean, a good example would be Nigeria. When in the case in Port Harcourt, everybody thought, oh my God, here we go, another focus. But actually, that's the good news side. Mali, Senegal, and Nigeria were all able to contain it with appropriate public health measures. Now, so what we might have kind of a disagreement about what counts as a global problem, and we can discuss that because it's a thing that people in global health like to discuss. What is a global health problem? But I think The other side of the coin was some of the early models saying that, it was going to be in Tucson, Arizona yesterday, and, 1.5 million cases, some in West Africa early on. So where we are now, I think we can have, we're probably got a better purchase on the fact that it's a slow burn and it's contained in a local environment. And when you think back on it, you're right. It doesn't have the capacity for sustained transmission. You've got to get up close and personal. The people where the transmission was occurring aren't the type that are likely to hop on planes and travel around very much. And so it's actually just stayed as a slow burn in 3 areas, largely in what the big game changer here was a crowded urban environment. There'd never been an Ebola outbreak. That's a really key, I think, novel learning from this outbreak. But whether it's a global health problem or not, I'll let my colleagues or anybody can weigh in on that. Yeah.
Yeah, no, I mean, I think you make a great point. In terms of, I think there were many global aspects to this. I think there were also many bullets ducked where this could have gone in a different direction. I mean, what I've seen in terms of the Nigerian epidemiology, I think one has to remember there's a counterfactual universe where, X thousand person hours weren't put into meticulous contact tracing, isolation, quarantine, and this did break out in, say, Lagos. I think we could have had a different situation, and it wasn't clear at the time which way that one would go. When I was at the IMED meeting a few months ago, there was a wonderful virologist from Kenya who ranted about how lucky, from Nigeria, who ranted about how lucky Nigeria had been that Mr. Sawyer had gone out the VIP door of the Lagos airport where there was no one there, rather than apparently the other door goes out into a crowded marketplace, that he had chosen to land in Lagos at a time when the public hospitals were on strike, so had to go to sort of a private institution where there weren't a lot of people around. So, who knows? I mean, there are many